Welcome to the Living Medicine Podcast, where we talk about ethical medical use of psychedelic psychotherapy, teaching skills, examining the issues, and interviewing interesting people. Now let's start today's show.
Hi, I am Dr. Sandy Newis, and I'm here with Dr. Signi Goldman, my business partner, and we are the Living Medicine Institute lead trainers and co-founders. And we're going to just do a brief kind of discussion about the use of ketamine for trauma. This is something that we regularly get asked about in our training programs. And there is a prevailing view in the field of one, it's not used for trauma, or two, it's used in this particular way for trauma. And one of the things that's really interesting about that I have found, Signi, as you know, in our collaboration is you and I do trauma work really differently. And yet I think we've influenced each other over the years to where maybe it's not as different anymore. Maybe it never even was, but we come from different frameworks and around what is effective, what works. And so we just want to kind of have a little bit of a discussion about, some of those different perspectives. We're going to move more into in future podcasts kind of about more kind of how-tos and what to do, but let's kind of just stay on that macro level for right this moment.
Yeah, we get asked this a lot. And there's the question of our different backgrounds. You have a more somatic background. I have a more of a exposure therapy kind of background. I have a psychodynamic background. You also have the trauma and resilience background. So we have these different, things that our careers have brought us through leading up to this work. There's that. But then there's this question that comes up because we work in psychedelic world and we run training programs of how does one do trauma work on ketamine? This is a new variable. And the ketamine itself affects the way people process trauma. And so there's been these really, kind of funny, interesting conversations that we keep stumbling into over the years of I have my skill set for how to do trauma work, but on ketamine, people go in this direction or this happens. You say the same. And then our trainees are often like, what are you guys doing that's the same versus what are you guys doing that's different? And so we're going to, open up this particular podcast in a few minutes to questions from actual trainees who volunteered to come on and just kind of talk this through or hash this out. But I think maybe a nutshell version is we get a lot of questions about how much one can do exposure work, which by what I mean by exposure loosely for this conversation is people sitting with the trauma, people being present with flashbacks, or even intentional, prompted exposure work, versus how much you work with creating resilience or resourcing people intentionally or increasing their ability to tolerate well-being, which is a thing I hear you say a lot. The phrase growing the good, I think you use a lot.
I got that from Rick Hansen, Buddha's brain and all that.
Yeah, we all got things from somewhere. Yeah. But it's interesting because our trainees will say, wow, both of you guys are full-time CAP providers and both of you guys work with trauma, which is true. Are you doing the same thing? So do we think we're doing the same thing?
I think now we are doing much more of the same thing than we were in the beginning, which I find interesting. Is that something that kind of we taught each other, we influenced each other? Is that a natural progression of things?
Well, this is where the conversation gets kind of funny, is that we don't sit in each other's sessions. So you don't watch me and I don't watch you.
I don't want to.
Well, we have videos, we've seen each other's video sessions, but we're not really in each other's practices like flies on the wall. And so this really has to become a conversation well, what are we doing? This conversation comes up because we train people. So as you listeners can tell, we've had this conversation before and we're just kind of having it in a public forum because it's super interesting.
Right.
And the working theory that you and I've tossed back and forth is that what we're doing may look more similar to each other these days, not so much because we have taught each other anything, but because the ketamine steers it in that direction. And I think just to put that more succinctly, if you are a therapist that, emphasizes more resourcing or resilience, ketamine does facilitate resourcing or a sense of well-being and working with. If you are a therapist that does exposure work, quote unquote, like I'm not using that. I'm using that in the sense that I mentioned earlier. Ketamine can facilitate that going better than it does in kind of ordinary awareness. But what the ketamine, if I can just anthropomorphize it for a second, really seems to want to do is to toggle people back and forth, right?
Right. For sure.
So if you go in just with an exposure lens, my experience, and that would be a mistake to do that. But if I may have had that bias more in the beginning. If you go in and just with that lens, it's almost like the ketamine will like, I don't want to say force, will nudge you as a therapist towards the fact that the client wants to resource or is starting to resource spontaneously. And then you follow that, right? And I'm curious if you go in with just if your lens is more about resourcing and well-being, you and I have talked about, does the ketamine and the client on the ketamine almost instinctually toggle themselves towards what I would call exposure work?
Yeah.
So is the ketamine, if we can think of it that way, trying to get us to do both?
Yeah. I mean, that's honestly what it feels like to me is that, and that, what we're doing is kind of following the threads. One thing that I find useful in my work is that I do educate about resourcing and the importance of growing the good prior to doing the work, because sometimes clients will be like, wait a minute, am I just like high and feeling good? I thought I was here to do, really hard things. And really, at a nervous system based level, especially with somebody with complex trauma or chronic stress and anxiety, or really any chronic mental health condition, the ability to notice, tolerate, and sit with well-being is a very relevant clinical outcome to be able to feel safe, feeling better. Mm-hmm. And so, so it's not just that we're like moving towards feeling better, it's that we're developing safety in feeling better, which is one of the artifacts of trauma. And, one of the things that I had been drifting away from in my traditional clinical practice prior to us working together is actual processing of identified index traumas, right? Which is harder when you've got complex PTSD because it's sometimes harder to get at the thing. And now I notice that naturally emerges. And so this toggling that is really pendulation that really comes out of somatic experiencing happens naturally. So we can just work with it and it's just there. So working with that with intention is, I love what you said about maybe just the ketamine itself is bringing us closer together, because that just naturally seems to happen, which then begs the question about how much we're actually making it happen. But that's, again, how do we know that?
Well, that's, I've thought about this, and that comes to this whole thing we teach and we've experienced of this non-directive approach. And the idea being that what needs to happen for the client is what's going to happen. And we are actually teaching people not to prompt or steer. So neither you or I kind of steer the session. That's a big part of our ethos and what we teach. But in the beginning, especially, I think there was this curiosity, and it's a good learning. It's a good teaching point, because we have a certain lens. Are my clients having more exposure type experiences because I just have that lens, and are yours having more overt kind of resilience, resourcing focused experiences because you have that lens, even though we're not intentionally steering them? That was one of the early conversations we had. Well, that's interesting. Like, that's a good thing for us to track, and especially and to teach trainees about. And as we were both being curious and making an effort to be non-directive, I remember us, talking a couple times, over the years about noticing that the client's nervous system on ketamine, or maybe you could think of it like the ketamine itself knows this, but something about the client in the altered state, whatever that wisdom state that they are, that unconscious guidance that they have, wants them to do both. Like, I think healing looks like some sort of processing of fear content in a safely held way where they have agency and in collaboration, and some sort of sitting with and anchoring in a new sense of resource. And those two things, that the trauma sessions I've seen, over the years, is like, if you think you're going to go one direction, you may for a while, but eventually the client will just spontaneously go the other direction. And so I've learned in a way now to just expect both, and to have languaging and sort of, like intentional ways of working with both. But I feel like this is just me. I'm curious what you think. I feel like if I do a whole session that's kind of exposure-y, just to say it, be informal. The last part, like right before the tail, the client will just drop right into some sort of resourcing thing, whether I say anything or not. And then I'm just kind of mirroring that. They just automatically do. Some sort of inner guidance does that. And I'm curious if the opposite is true.
No, the opposite is a little bit true. But it, then, I mean, at that point, then we look at the parallel process about to what degree does somebody use, like, oh, let's just look at happy things in our life and avoid, looking at the hard stuff. Like, how much of that is happening for them already? Like, what are their defenses around going to the thing? So I think when you do a lot of emphasis on resourcing and well-being, that you also have to be more intentional about holding the client's intention. Like, is there added benefit in processing hard, traumatic event and traumatic material directly in kind of an exposure piece? And if it doesn't naturally emerge and you've done several sessions, which I often do series, then I do prompt them more. Like, so, I've noticed that we haven't really processed some of that stuff.
And why do you do that? Like in your
Because I have found that there is tremendous value added in doing it for some people. But even then, I still won't push it. I'll just prompt it a little more. Like, I might say, like, hey, so I'm going to bring this up when we're, a third of the way in, just to see if it's like we naturally go there. And if the psyche doesn't naturally go there, then I'm not going to push it.
Right. Yeah, I agree. I mean, pushing anything would be kind of unethical in a psychedelic context, at least the way that we teach, right?
Right.
Which is interesting because that's why we've always been so curious. Like, why do my clients tend to have more exposure type stuff if we're neither of us is pushing anything? Yeah. Is it because, like, it's so fascinating, right? Is it because I have that background, like something about the way I just use words or I language things? But it may also be the way I talk in preparation, because I think I may front load in preparation the possibility of that. And maybe that is why it spontaneously happens for people. And it's just something it's just interesting. Yeah.
I mean, that said, I have done things based on your influence somewhat differently, as a result, where I have had more sessions where a client has come in like fully prepared to process like the thing. And we just do that because we start with that. So that is more directive, like, but, meaning, but there's a shared agreement that that's what we do. It's a collaboratively developed shared agreement that is what we're going to do, which is really different than material that's sort of like, it's lurking there and you're kind of looking for the place where it might emerge and then it does emerge. Those are two different kind of ways to approach a session. And I do more of the former now than I might have initially, probably because
I think one thing I would name before we close this, just as a kind of interesting summary and a like to be continued statement, is there's how can I best language it? I think that, first of all, these are controversial topics. There are many people out there, many of you even listening, with very strongly held opinions about how trauma work should be done, period, and how it should be done on ketamine also. And there are camps. There are camps in trauma world, and they don't always agree with each other. And some of them think that the other camp is doing harm. So we realize this is like, swirly waters here that we're wading into. And yet it's important because we run a training program to think about it. And we do trauma work ourselves a lot. And, we have to be transparent about the fact that this is a nuanced and evolving conversation, and how do we do it best? And that's what we're trying to do. That being said, to me, it like the two things that arise are there's a bias in some types of trauma work to under-resource people, or there's a concern, you're not resourcing, like you're just putting people, they're facing their fears, but they're not learning how to resource, right? They're not learning how to regulate. And you're dysregulating them without, in a way that is not therapeutic. And that from that camp, you would say, do less exposure and do more resourcing. And that even on ketamine. Right. And then there's another line of thought.
Associating too, like, they say they're getting better, but actually they're just dissociating.
Right. Are you just making people dissociate? This is another really valuable line of inquiry, especially when you're putting a dissociative psychedelic in the picture. So this is a really rich conversation. Yeah. And there are more than just two camps, but to oversimplify, I would say there is another camp that has maybe been more the world that I came up in, which is to what degree resourcing and regulating can just become avoidance, or where does that happen, right? And is that what people are already doing too much of, right, themselves? And are we just furthering that? And so it's this fascinating place where I think we're doing the right thing right now by just asking the questions and having this conversation openly with trainees who come from many different backgrounds themselves. And I think it's also waters that the whole field collectively needs to wade into talking about more. So we plan to have a lot more podcasts talking to trauma people and people doing trauma work, because it is, it's tricky territory, but it's beholden on us to go there.
And I want to add one more piece that I just find a very deep emerging interest, which is, again, and I don't think that this is not the same as resourcing. This is like just a track that emerges in psychedelic work about deepening into well-being and kind of how that impacts the default mode network. Like, and can we be more intentional with that? And is that trauma work? Like, so to be continued.
Yeah, to be continued. And we will have some trainees coming in, ask us some questions especially about this stuff. And let's just see how we field it together and make it like an ongoing conversation. It's good stuff. So Sandy and I are joined right now by some of our trainee community. We have Barry Bondurant, who's a licensed clinical mental health clinician from Asheville, North Carolina. We have Barbara Conald, who is a board-certified psychiatric mental health nurse practitioner. And she runs a psychiatry and ketamine treatment clinic in Greenville, North Carolina. And Amy Maima Nicholson, somatic psychotherapist and shamanic practitioner from Madison, Wisconsin. So we really appreciate you guys joining us. Initial thoughts or questions, and we'll just hash out anything you guys are curious about.
So I do. So how would you manage a person with complex trauma who's not well resourced and becomes dysregulated and dissociate?
You want to go with that one, or you want me to take it?
Yeah, I mean, I personally really strongly believe with complex PTSD that we need to do a lot of education on the front end. So for me, preparation involves educating about what happens with complex trauma and what happens with the nervous system. It involves teaching somatic skills, helping people connect to their body, and also some basic mindfulness prompts. So connecting somebody as they move in, we practice it in preparation and do it in the chair as a starting point to help them connect different parts of their body to the actual chair. So when somebody in a session begins to dissociate or becomes dysregulated or gets lost and doesn't know where they are, and gets into a fear response, I'm first going to go to that. But that's assuming that I've already taught them that. If I have not, for whatever reason, then I'm going to orient them to the room. So I might remind them of where they are. At times, you might even have somebody lift up their eye shades and look underneath if they're really panicky so that they know. I remind them of my presence. If I've already done consent around touch, which I do all the time, which I think is critical, then I use touch. And I might use touch on their arm, or I might use touch on their chest if I have consent. I may also have them touch their own legs or touch their arms. These are my legs, these are my arms, and have them connect, notice the sensation, and speak those words out loud. So really some very, intentional grounding. And from that perspective, it's not that much different than when somebody dissociates or becomes really dysregulated in the actual session. And again, that's also assuming a fairly high level of distress. And that's getting in the way of their ability to process and to move through the session. So if they're just kind of not, if they're more blank or more dissociated, or I don't know where I am, or I'm not sure what's happening, that's kind of a different piece around using deepening prompts and being really curious about exploring where it is that they are. So, it's almost like which level of activation are we looking at? Kind of like the low zone, the shutdown, the lost, the disconnected, or is it more in a state of activation? And in that case, we also are tracking the IV carefully, because sometimes people might start moving. and, helping them kind of orient and ground themselves in space. That's really, to me, that's really different than actually working with the state. That's helping somebody through that more acute piece.
Mm-hmm. Thank you.
Are there other curiosities you have about that? Like how to handle people who are dysregulated, or does that bring up any other questions?
It does. I just remember a client who became more dysregulated in between sessions. And, I really appreciate you balancing the exposure therapy with the somatic kind of work. But when somebody is not well resourced, it can be challenging as well.
Mm-hmm. Yeah, teaching somebody how to resource prior to going in, I think, is of critical importance. And resource can look like a lot of things.
Yeah.
Like going outside and sitting on your porch. It can look like sensing in, to a moment or something that makes you feel good. It can mean, petting your cat or your pet. It can mean, awareness of some self-care skills and the importance of doing it. A lot of times what I believe is that when people also expect what's going to happen, so helping somebody understand that sometimes things actually might get worse before they get better is often a really, really useful platform. And that's really, again, analogous to more traditional psychotherapy too. When you do trauma work and people go deeply into, some of the painful material that they've been guarding against or have been well defended by, sometimes people do become more dysregulated or they go into a dissociative state. And sometimes they have a hard couple of days, right? Or hard couple of weeks. Like sometimes the only way out is through. And so helping people really understand that this is not a linear process. In fact, when I do a lot of infusion series, and it's pretty predictable that around, between session 3 and 4, people are going to start to think they're getting worse. And so when people understand that that's a part of the process and you kind of front load it, you don't say this will happen, but you say this could happen. And that's actually might even be a good sign. So then people have a lot more faith in what you're doing.
I appreciate that. Thank you.
I definitely agree with talking about the possibility of this happening in preparation. Mm-hmm. And then there's this obvious maybe piece about knowing your client. I feel like usually the people that I've had that have become the most dysregulated are the ones I suspected would, because of what I know about their psychopathology or their particular trauma patterns. And one way that you can preempt that just as a technique ahead of time, it's not always, fail proof, like it doesn't always work. But if I suspect someone is going to become more dysregulated because they have a certain fragility or something shows up in their symptoms that make me, that I see a pattern there. There is this exercise that you can do in your first session where you take the entire first session just to get them comfortable with navigating, deepening, or lightening the medicine. Obviously, that's easier on an IV, but you can do it on any route because what you do is you put them on a relatively lowish dose and you tell them, all we're going to do is work on your comfort level and your sense of safety with the sensation of feeling altered. We're not going to address any content or process anything. So we're going to put you on this. We're going to, first of all, check into how safe you feel right now in your body and have them really be mindful, really actually make sure they're authentically tracking that, a sense of safety. And then when they get on the medicine, you have them track, like you prompt, notice your safety, notice all the things that you're doing, the safe, some of the similar prompts Sandy named, and then you can prompt them to lean into the medicine more. So they can orient more. Orienting more would be like all the oriented things people do, like touch, contact, tracking the room, trying to talk to you, like Sandy said, touching themselves, sometimes even taking off their eye shades. That would be like things they do to orient, or being more verbal with you. And then you can have them do, move away from all those things, get quieter, get less verbal, put their eye shades on, deepen in. You can even turn the music up. You can have them go deep in and let them feel it a little more deeply, and then have them track how comfortable do you feel with that. And now notice that you can lean in or notice that you can lean out. You have to be at the right dose range for this. But if you do that, a lot of times what they'll do is they'll kind of tiptoe in and then they'll try to go a little deeper, but then they'll notice for themselves that they can kind of back out again. Then they'll do it again and again. And it creates this sense of safety in them that, I can pace this and I'm not going to become like overwhelmed, like falling off of a cliff. And then sometimes I do that as the entire first session. And then in the second session, I have them kind of self-titrate the dose up. I'm not saying that always prevents any kinds of fear episodes, but I have found it really useful with people not all of a sudden getting shocked or overwhelmed by the altered sensation or something like that in one of the early sessions.
Thank you.
So Maima, you asked kind of a follow-up. Do you want to speak to that?
Sure. This is Amy from Madison, Wisconsin. So I guess I'm just curious in terms of what Barbara was saying. She noticed the dysregulation in between. And so my question is, would that be a good time to just do more integration then before doing a second dose? Like with someone who we might predict to kind of unravel, how much more preparation and how much more integration might we do? Like, could we just slow it down and really titrate it, and take several sessions to prepare, several sessions to integrate in between, or is it sometimes better to go right into the medicine?
I'm going to go first on this one and then see what Sandy thinks, because it's kind of interesting. It's a little bit how you frame whether getting dysregulated is a problem or not.
Sure.
We think so. Obviously, we don't want to cause distress, and we certainly don't want to re-traumatize, and we don't, that all that goes without saying. So some clients are more willing to have those experiences than others, I've noticed. Like for some clients, we say, okay, this might be part of it, and they have a willingness, and others don't have a willingness. So there's almost like a willingness variable. And the thing you said about can you just take more preparation time and all that is a answer. I think that's what a lot of people do. They slow down, they take more preparation time and more integration time before the next session, especially if the person's fear is of the medicine. And I guess I want to hear what Sandy actually does in that kind of a context, but I often am having a conversation with the client about their willingness to do it again if knowing that might be the experience. And then we are doing realistically, we're usually lowering the dose. And then I'm tracking along with them, watching to see if the experience comes back like in a collaborative way, if that makes sense. And then we have had a conversation that if that happens, we may need to stay with it, or are they willing to stay with it if I'm going along with them? So that way of framing it is you're not really trying to avoid the dysregulated experience that much. But there are matters of degrees here. I mean, are you talking about complete panic or something like that? That would be totally different. Mm-hmm. Or are you talking about they're very afraid of what they're experiencing?
Yeah, I would say those two things would be different.
Yeah.
It seems to me you're right. Like I have a new client that I was meeting with today, and it's the first time she's ever done therapy ever. And just within 1 week, she started to unravel a little bit, which is normal when you start to enter into a relationship like this, where you actually start to feel your feelings and notice your patterns and look at yourself. So it makes sense to me that people would feel a little unraveled and dysregulated, or whatever you want to call it, right? So it also seems like it would be a really great skill to learn how to be with yourself in those different states rather than avoid, right? In some ways. And I don't want to use the word avoid, but you were mentioning that before in terms of tying that back into like resource and regulating can become like avoidance. So I know it's a little off topic, but kind of ties into what you were talking about before. And I just think it's really interesting because I think building capacity is.
Yeah, it is really interesting because you don't want, yes, none of us want our clients to suffer. And also the presence of a dysphoric feeling in between sessions, especially if it's a new one, is often kind of valuable content, actually. Now, you may not know what that is during the in-between session stage, like when you're doing integration and preparation for your next one. You may not know why they're dysregulated. I mean, this is true for trauma work in general, of course. Like someone can be dysregulated doing trauma work. But a lot of times they'll be saying, I am feeling such and such a thing. And when you go in the second session, then you can explore what that thing is or what that feeling is and find out if there's content behind it. And I can go into more detail if you want. But so I don't necessarily see it as a problem. I have compassion for the client's situation and I don't want it to keep lasting. But I guess I'm just repeating what you're saying is that maybe it's often part of the process of trauma work, period.
I
But
think it's also a big assessment piece. Sorry, you want to say?
I was just going to say, I wouldn't let anyone leave my office in a really dysregulated state. We're talking about matters of degree here. I hope.
I mean, I think that it's also a huge assessment piece, that there is a really important piece in preparation of assessing somebody's relational capacity, their capacity for emotional intensity, their capacity to resource, their capacity for self-regulation. How much trust do they have in you, in the practitioner? So I think and are you always going to get it right? Absolutely not. But if your assessment is that they're going to be more fragile and they are more prone to that fear response or they are more prone to panic, then you're going to want to just tell them we're going to want to do more preparation. And there's where that piece around the parallel process comes in. Like, are they afraid of the medicine? Are they afraid of the content? Or are they afraid of intensity? Are they afraid of you? Are they afraid of being vulnerable? Like, what are they afraid of? Because I think that, and again, are you always going to get that right? No, but that's also going to inform what to do next. Like, if they're afraid to be vulnerable in front of me, and that's really where the panic, then I'm going to be wondering how else does that play itself out in their life? And then it's going to be a heavy relationally oriented time. And I'm not going to back out of that. If they're afraid of the emerging content, then we might want to slow that down. But you got to I also have a lot of faith in somebody's capacity. And here again, that's where, my belief about the importance of building in these skill sets and them understanding a trauma response and understanding self-regulation in the brain and the nervous system and how that works prior to going in is so important, because then you're not trying to teach them when they're under the influence of the medicine. And I always, if somebody does get really dysregulated during the time, I just assure them, like, I'm not going to let you stay in this. Like, I promise that I will not let you stay in this. And then shall we go deeper or should we back out? Give them a choice. Do we want to keep going or do we not? I will not leave you. I will not let you stay in this. I got you. That's when it's really important to communicate through your voice, through your energy, through getting in close. Like, I got you. And when somebody has that level of trust, like, let's just put content over here, like that in and of itself is a huge piece of trauma work. So always really holding that relational lens and that relational capacity. And then that would also inform how quickly we want to do it again. Like, I really believe in expansion and contraction. Like, I really believe in the power of the medicine to help maintain expansion, softness, a lightness of spirit, the ability to calm the dysregulation. So do we want more time between the medicine? I don't know. That's more time for contraction. Right. That's more time of like returning back to like normalcy. Is that our goal? Do we want that? That depends on how incapacitated they are.
Mm-hmm.
So, like, I think in terms of the 3Ds, duration, distress, dysfunction, how are they doing? Like, are they unhappy or are they not functional? And so really it's a really an ongoing assessment. And like what Signi said, I mean, being dysregulated and being upset, and, like, you don't want to send somebody home that way, but do we also really want them to be perfectly buttoned up either? Like, that kind of depends on where they are. Like, and that's where doing more than one session I think is of critical importance for complex trauma, because then you have the opportunity to kind of go in again and it becomes a sequence and a process, not just like a one and done kind of thing.
And I'll say, for the sake of the audience, this may go without saying, but we're talking about the fact that some dysregulation during the CAP process, even in between sessions, may be okay and is content and you work with it and everything Sandy has just said, that is not the same as sending someone out at the end of your entire treatment still dysregulated. So I know you guys know that, but it is your job by the time you've kind of graduated someone from your program or discharged them from care that they are in a regulated place. So I just want to make sure we're being clear about that distinction.
This is so helpful to me. I'm talking to my first person who may do CAP with me, and she has complex trauma, and I've known her forever. And I was talking about the dysphoria, dysregulation piece, because I see that as something that almost certainly will happen for her. She doesn't feel safe hardly anywhere at any time, maybe never. And she told me that she's been playing with psilocybin and she has terror and panic, but she's proud that she gets through it and comes out and does it again. And so I really like thinking about dysregulation possibly as just being a way that a person learns to strengthen themselves by learning to tolerate it. And it's just quite lovely. And with the ketamine and the expansiveness, it seems like a perfect place to do that.
I kind of love that you say that because I am an exposure person, as you guys know, even on ketamine. But one of my things that I have learned doing exposure work with people is that it can be an empowering experience, even if it's not fun. And then a lot of times, even when people have like spontaneous fear-based exposures, or spontaneous exposure experiences, they will be very afraid. Like I've even had called Maydad in and be like, okay, this person, like we're doing all the things we're doing acutely that you guys asked about, like reassurance, all the, and I will think afterwards, like, oh man, that's rough. This person's never going to come back. And it's surprising how almost always they'll say afterwards that they're so glad it happened, that they feel stronger in some way. And they almost because some part of them believed that they could not do it and they could never do it, even unconsciously. And now they feel a shift around that. And so, just putting that out there, I've seen that quite a bit.
Well, and another kind of, sort of, I think it comes out of some of the somatic schools of thought, but is also look for the helper. But more than that, I would say, like, look for do you watch very carefully when you have like a going into the content and, kind of a, reliving of that or whatever we're going to call that, like the exposure piece on that. Watch for the moment when they started to free themselves, because that will almost always happen. And that might even be just a cognitive shift. For example, I was working with somebody who was experiencing abuse in the family, and there was a moment in which they started locking their door. And so I noticed that, and I was like, so you started locking your door. And that became a big integration piece. So be tracking, like, when did it shift? When did the story shift? When did they know they were safe? And that's a very kind of somatic tool, and that's a good, like, if somebody's really just like looping on the content, we can start to watch for that. And I don't mean necessarily interrupt, but watch for that, because out of that comes the work in integration that can emerge and often does around restoring it. Like, I fought my way through this. I survived. I am a survivor. I was saved. Or look for the moment when they were finally safe. And that's also then kind of your sort of runway kind of into kind of the way out around, like, moving back towards resource and self-regulation. And that happens a lot. And when you can, I think you can lodge that restoring even more deeply into the psyche with altered state work.
There's a piece I want to throw in, which is this idea of tethering, which I don't know that we've formally taught you, but we have referenced it. And tethering is the awareness that the client has while they're altered, that you are present. So this is one of the big differences between, like, recreational use of psychedelics and therapeutic use, is that no matter what they go through, they know that they have a companion who is checking it with them, and therefore they are not alone. And I use the word tether because people often feel like they're floating out or floating away or leaving, and their relationship with you is like a rope back to ordinary reality. Like they know they have this rope back into the room in the office where the chair is, where their body is, where they're going to come back, even if they're floating somewhere very far from that.
Mm.
And you can do tethering in different ways. One of the things that the docs at our clinic have said that Sandy and I do differently, which I thought was interesting, is that she uses like consistent touch more as a tether, whereas they think that I use a lot of verbal cues to tether people because I'm kind of saying constantly, I'm right here with you, I'm still here with you, and stuff like that. It's the same concept though. It gives the person the felt sense experience that, okay, no matter what's going on, I can also sense this connection back to my therapist, and they are not leaving. They're not gone. I'm not, and that actually, I'm bringing this up in the context of a trauma conversation because that's a lot of times why scary experiences aren't as traumatic as they would be if the person had it on their own, because you're accompanying them through it. So, I've had some very intense, what you'd say, exposure type sessions or people in very intense flashbacks of severe traumas, and they are reliving the fear for sure. And on the memories, it's very vivid. Every sense, sight, sound, smells, touches, it's all coming back, right? And they're hyperventilating, and they're all of that is there. But they will tell me afterwards that they knew that I was also there.
Mm-hmm.
And so I just want to name that's a skill. And I think where therapists don't do this well on a psychedelic is where they don't have some sort of technique, whether it's verbal or touch focused, to maintain the client's awareness of the tether, so to speak.
I think it's so important to just kind of put out to not just us, but the whole audience that ketamine can be an incredibly relationally oriented intervention. Like people think, like there are a lot of people who do like, oh, how could you possibly talk on ketamine? Well, you just do. And you do it because you've built a relationship. You do it because you've, done good preparation. You do it because you sit closely. You do it because you've told the client that that's what we're going to do. And so, when I first started, there would be way more times when clients would sit quietly. So I'm obviously doing something different now that almost never happens. And when it does, then it's just part of their process. But that piece, I think this actually comes from the PSIP, which is kind of a teaching of Saj. What's his last name again?
Rajvi.
Yeah, that, you're not just experiencing this, right? You're experiencing this with me. That's also very much interpersonally oriented psychodynamic psychotherapy, is that you're experiencing this, but what's different is you're not alone. So really being in there with them and then utilizing that and then bringing that up in integration. What was it like for you to have me there? Maybe I want you to feel my hand on your arm and I want you to just deepen in the awareness that I'm right here with you. And let's just be curious about how that may or may not shift things. And just really getting in there and be sweet but strong, like, you know what I mean? Like be so gentle, but also like I've got you, like at the same time. And then that becomes a major piece of the intervention.
Yeah, I agree. There's a phrase I use a lot, which is you guys might find useful, which is no matter how blank it gets, I will still be here. And that is because what happens usually is people get into a fear state. It's something is unfolding that they feel is going to get worse or more intense, or right, like I'm starting to lose my awareness. It's going to get worse. There's this, oh no, feeling that's often behind. And people will say things like, all right, I'm going to make this up, but say someone says everything is going black, or I'm losing awareness. Then I would say, no matter how black it gets, I will still be here. It can get even more black. I will still be here. Or no matter how much awareness you lose, you can lose all your awareness. You can just close down. No matter how much, I'll still be here. I'm tracking along. Like, so the no matter how much statement, and then, and this brings us into the topic of dissociation, because I mean, this is a juicy topic. Is dissociation bad or good or neutral? I mean, is this a bad thing if it happens? I mean, is dissociation just another form of an altered state that we can work with? And those are things that are still rich conversations. But if someone is even like scared enough that they're dissociating, I will often even do that there. Like no matter how, like dissociation, they'll feel like they're fogging over, or they're going somewhere floaty and nice and comfortable, but they're disengaging from the process in some way. And they'll often have a visual image that goes with that. Like I'm going into a foggy cloud, or I'm falling asleep under, they're just, whatever it is, it's like, I'm out of here, in some sort of like, and then I will say things like, no matter how foggy you get, I will still be here with you. Or no matter how far away you go, I will still be here. I use those statements even in those moments as well, because that's also something that's new. I mean, they're used to dissociating and everything goes away. But if there's, even in those moments, you can be present with them, and that creates like a something new that hasn't been there before with those experiences. I have begun to think of it as a state that contains useful content.
Mm-hmm.
So if someone is dissociating, you can experiment with saying, no matter how dissociated you get, I'll still be there. I mean, they probably won't use that word. They'll use some other word, like I'm zoning out or something. No matter how zoned out you get, I'll still be there. And then just sit with them and act. And like, I have tried this because I was taught this by a teacher once, and just let them dissociate even more. Like, you can dissociate even more. I will still be here. I'll still be here. Now they'll go really down to a very limited amount of like awareness. They'll close down a lot. But they'll still hear your voice, right? Especially if you're on ketamine. So they'll go to their dissociated place and I'll say, no matter where you are, how small and dark you are, whatever words they're using, I'm still here. Like, and I will sometimes check that they're tracking my voice. And if they say yes, then what we're doing is I'm going with them into the dissociation as well. And a lot of times then you have to allow them to stay there a long time, because that's what they're doing. They're not in a hurry to come out of there. So you're just sitting in there in the dissociation with them for a long time. And sometimes in that place, I ask them the relational piece that Sandy mentioned earlier, like something like, are you aware of my presence here with you? And, how is it to have me here? Or how are you feeling? Like, how are you feeling towards me? Or what are you feeling if the emotion is between us? Or those kind of questions. And a lot of times what that gets to is like whatever the relational pattern is that triggers the dissociation.
Mm-hmm.
And that they often speak from very kind of a young part at that stage. But anyway, I'll probably edit all that out because that's a little deep for podcasting, but it's a thing. And it's really interesting. Like,
it's perfect.
Well,
Yeah.
is dissociation actually a problem? Like, we are putting people in altered states anyway here, and we're going with them. And dissociating is the psyche's ability to put itself in an altered state that we learned at some point early on. We're altered stating ourselves when we dissociate. Yeah. And there's just as much content potentially in there as there is in other forms of altered states. It's just that we're not used to exploring it. And it's a very slow, very sluggish place.
Mm-hmm.
There's a lot of sitting there, and like the session gets really slow. But it's almost like you're aligning with their ability to do that so that they stay in dialogue with you. Mm-hmm. I think it's really fascinating. Some of that I did also get from Saj at Psychedelic Somatic Institute. So plug for him for teaching me enough that encouraged me to try that more. I'll put a link to his information because we've referenced him a couple times in here.
Thank you. That would be good.
Yeah, he's really good with teaching the idea of like working with dissociation. At least that's my words. That's not his. I don't know if he would agree with languaging it that way. And the tracking of the transference pieces, like Sandy mentioned, the relational pieces and how that triggers parts and things like that. On ketamine, we're talking about.
Yeah, I think, I don't think we should be afraid of it, but you want to track it carefully in ongoing integration and make sure that somebody's not, deeply into that. And how you do that is kind of a variety of different ways, but watch for it. Utilizing your awareness of the client. Are they fully present, or are they like super blank?
I think it's helpful to notice like the different degrees of which like when you come back, like noticing when you come back and then noticing when you leave, and, tracking the reassociation. And I found that somatically, when you can start to track the reassociation, it's kind of a trip. It's really helpful in the integration process too. And I love what you were saying, Signy, about your voice was such a tether for me during our integrative retreat. And so profound to think about this going into a dissociative state with a tether and someone with you relationally to be there with you.
It's pretty transformative.
Mm-hmm.
Yeah, it's really amazing.
Because it's new and it's gosh, yeah, I don't even know how have the really eloquent words for that, but it's like that's the safe hiding place where you hide away from everybody and everything, and a therapist has never gone there with you before.
Yeah.
Right.
Yeah.
And that may not be fully conscious that there is, but it's like it's a felt sense. They have a felt sense of that.
Yeah.
I think I'm sure the audience and listeners have lots of thoughts or lots of, I can see this being contentious in some ways, but it's how do we think of what dissociation is? And yes, obviously you don't want people to live with maladaptive dissociation as part of their outcome.
But, to have somebody there with you for the first time, the thing about ketamine that's been so lovely to discover is how relational it can be and how interpersonal and how healing of different kinds of relational wounds that it can be. And to have somebody when you freak out and disappear that's right there with you and in your expansive state, it sounds like it could be amazingly healing to do that and normalizing. I don't have to be ashamed. I've got somebody with me. And when I come out, they're still there. And it just sounds beautiful.
Yeah, a lot of times there's not a lot of words to it.
Mm-hmm.
Very somatic and, quiet. Yeah, that's an interesting subject. I don't want to take up all you guys' time on that, but it's just since dissociation is such a thing.
Mm-hmm.
Yeah, it is a kind of avoidance for sure of content, but I think there's content in the avoidance. But it's something I'm curious about too.
I think it's really important to say, processing content is only one part of trauma work. There's the processing of the content, there's the relational component, because that's, what people kind of struggle with in response to trauma is often relationship. It's often the ability to shift state, have your nervous system be flexible in the face of different demands in the environment. So, tracking differences in relationship, working on a relational component, tracking differences in state during session and then after session. That, helping kind of clients themselves move away from the idea that it's all about processing content. There's a place and a time for processing content, but that digging for the aha moment, that digging for the thing that's going to free us, sometimes that does happen. But other times trauma work happens in a much wider range of ways. And so, just kind of putting that out there that there's a lot of different ways to work with trauma, particularly using ketamine. So,
yeah, that's that state shift. Sometimes they never have a story at all. Like they'll say, "I feel better." I have no idea why. I mean, because you just bypassed their whole storytelling, cognitive, part of them, and you worked with other layers of their nervous system.
That's really interesting to hear because sometimes with my clients, I kind of feel that, that's an important part of it. But I've also had clients who do just seem to get better without the narrative telling of the story or even it coming to a sort of a conscious surface level, but they've been processing it unconsciously. So thank you for putting words to that.
Yeah. I think sometimes what happens is even if we're not doing overt parts work, that younger or wounded parts that are kind of exiled parts, to use IFS language, are getting some healing through the interaction with the therapist. I do think that the interaction is relevant. Like Sandy spoke to these relational pieces or the things I spoke to with tracking the person or the tethering and all that, that there are younger parts that are getting healed without the sort of the client's sort of conscious awareness really knowing that that's going on. And so their symptoms just shift, right? Like they'll just be less vigilant or less. And I think this is separate from the pharmaceutical effect of ketamine, because we know that ketamine has antidepressant, anti-anxiety effects for sure. And I'm aware of that those happen in clients. But this is more of like a structural personality thing, right? They almost like parts of them are, but they don't know what that is. That's my suspicion of what's going on. But just as like what you're mentioning, Barbara, they don't know that that's what happened, and neither do I know for sure, because we weren't actually working with that part overtly.
Yeah.
That part accessed some sort of healing, like maybe the fact that Sandy had her hand there the whole time and said the right things at that moment, that part could release some sort of vigilance, and we never even got to know the part.
Yeah.
So the last thing is and if you guys have questions about this or don't, that's okay. But I think one of the bigger themes that comes up a lot that we get asked is this dialectic. I don't know, this back and forth between is resourcing avoidance, and on the other side is exposure re-traumatizing. So I think we addressed that in what Sandy and I spoke to at the beginning, but do you guys have clarity questions on that or thoughts on that? Or does it make sense to you that there's this sort of middle ground? And what does that look like?
It seems like it might be something, working with the person. Like, yeah, it can be re-traumatizing. It can be liberating. It can be avoidance. It can be learning to be safe. I mean, it seems like it's maybe not a clear, simple answer, but that with each person you navigate it.
Yes. I do think that. And I think where it becomes like, where we get asked it more is a strategy thing. Like yes. I mean, maybe the answer is just track for both those possibilities and don't assume. Maybe that is the answer. Don't assume that that exposure will re-traumatize them. And then don't assume that if they're leaning heavily into resourcing, that they're just avoiding.
Well, I like what we've talked. I'm sorry. I like what we've talked about before in terms of like titration and choice points, right? And so I feel like when we're titrating the trauma, we're helping our clients learn how to titrate their own experience with choice points. They can still learn to be with those different states, but they have more choice in terms of how to approach it. And I think that strategy is really important to just remember that we have that. It doesn't have to go from like 0 to 100, like there's always choice points available, right?
And you're referring there to something we teach in the training program about.
Yes. Choice points. We learned that from LMI. Titration is something taken from somatic experiencing, but people use that.
There's also the piece about, what is the client's intention? Are they there to process content? Like, is that the intention, that they want to process what happened to them when they were a child, or, the accident, or, the fire, or whatever it is that happened? And if you've done several sessions in a series and the person hasn't gone there yet, then that becomes, a question about integration. And that might something like, so I'm aware of the fact that, you wanted to work on these specific issues. It seems like there's lots of things that have been coming up around that. And we've been working with a lot of recalibrating the nervous system and being able to resource and to be able to regulate and, to be able to tolerate the emotion and to grow the good. And I'm wondering, do you want to really go there? Is now the time? So, and if so, then I say, so in this session, I'm going to prompt it more. I might even ask you, are you prepared to go into that? I might say, so we were going to work with this session by going into X, Y, and Z. And so I might even start that before before the medicine really starts to kick in. So you're really just like doing it the whole time. So that's also, I think, the real benefit of working in series especially with complex trauma, where there's a lot of different types of things and not one particular event. So you're building the relationship, you're building the capacity, you're working with, some of the different frameworks and watching to see if it naturally emerges. And if it doesn't, then you ask permission and then you move into doing that. And even then, if somebody's like, yeah, they want to do it, but then they don't really go there, like, that remains an open question. Is it my responsibility in that moment to kind of move us towards that? I've never really had that happen. I've sort of had that happen, where we were kind of like doing all of this work around it. That was also really important for the person. And so, Bessel van der Kolk has repeatedly said that you can do really good trauma work without ever telling the story. So I think there's a time and a place. It's just doing that dance because it's not really non-directive. Like at least I don't believe it to be. That's kind of common in the psychedelic literature. It's more collaborative co-creation, really.
That's a good way of putting it.
Yeah. Can I just say one thing?
Yeah.
All right. I used to be one of those people that thought exposure was re-traumatization, and so I avoided it. And now I think that was probably good because I didn't have the skills and the wisdom. And I think that exposure is traumatizing if you aren't skillful. That it's a very delicate thing. And I think that with ketamine and being expansive, and if you're skillful, then it's a beautiful way to do that. And it can be very healing. But that's just my own personal take on it. And I'm very glad I didn't do exposure, 15 years ago, because I think I would have hurt people.
Well, that's a good cue for our closing statement, because maybe our closing statement can be, don't shy away from exposure work on ketamine, but make sure that you are skilled at it and that you are also balancing it by tracking resourcing.
Yeah.
Under-resourcing. And then don't worry about over-resourcing people into avoidance as long as you're tracking that. Right. And you're not basically, so it's almost like maybe that is the answer, is just pay attention to both those supposed polarities and then continue to be curious about this thing that Sandy and I are curious about, which is is the ketamine sort of facilitating that even happening automatically anyway? What I'm beginning to suspect. Whether no matter which way the therapist wants to go. And so allow for that, because that's the client's inner wisdom, or that's their nervous system's actual deep knowledge about how to self-heal.
Yeah.
What I suspect is that on some very primal nervous system level, the healing instinct or wisdom of the body is to kind of self-pendulate, right? And so they kind of do that anyway.
Yeah.
And so don't go in with too much of an agenda, like we always say, and be open to it. So thank you guys for having the conversation this evening.
That was great.
This was wonderful. Thank
So
you.
many more questions.
But we'll see you guys at the next class. Thank you.
All right. Sounds good. Thank you.
Bye. Thank you so much.
Bye, everybody. Thank you.
Bye. Bye.
Thanks for listening to Living Medicine. We'll see you again next time. Be sure to click subscribe to get future episodes.